So the only treatment that we have to date that is curative or can lead to long-term remissions without maintenance is an allogeneic bone marrow or stem cell transplant. And so for any patient with high enough risk disease, a survival that's predicted to be less than 5 years, certainly transplant needs to be part of the treatment plan. But there are a lot of patients who are too frail, have other medical problems that might preclude transplant. Those more commonly happen the older you get. So we often talk about older patients not being eligible for transplant, but really it's about other medical problems like heart disease, kidney disease, as well as frailty. And so in those patients, with transplant not being an option, we certainly want to not only maximize the quantity of life, but the quality of life as well, right? So, and with those two kind of goals in mind. And we first of all don't want to make people worse. So we really need to be careful about selecting therapies that aren't going to incur large amounts of irreversible side effects or serious side effects that might land people in a hospital. And I think that's so critically important as we're now embarking on this age of combination therapy. We got data from the Transform and the Manifest trials. And if these combination therapies are too toxic, it may not be something we want to apply to those populations. And so to me, approaching someone who is older or more frail or has a lot of other medical problems, we kind of want to start out soft, right? And ruxolitinib is still a fantastic option. Not only can it improve spleen volumes and symptom burdens, but can actually improve quality of life, and which translates into better survival all over. Of course, that's more for patients who have intact marrows and good functioning marrows. And if the marrow is not functioning well, we think about alternative JAK inhibitors like Momelotinib and Pacritinib for those patients.